Welcome to the smartest doctor in the room. I'm your host, Dr. Dean Mitchell. First, I want to take a moment to thank my listeners. This podcast, after 2 years, and as we head into our third year, it's unbelievable, has now reached 25,000 people across various countries. So I still find this amazing, the power of podcasting. And fortunately, this gets to help me get smarter and more knowledgeable. And I hope it does for you, the listeners, as well. My guest today is someone I know very well, and I consider him super smart, and he's a really good clinician on so many levels. I'm going to date myself now for a second because, back in the 1970s, when there weren't too many TV channels, there used to be a commercial on E.F. Hutton, the brokerage firm, and they had this very memorable picture. It was on a golf course, and everybody was standing around watching this professional about to make this really key putt. And all of a sudden, somebody in the crowd turns to his friend and says, um, my broker is E.F. Hutton. And Hutton says, and everybody gets quiet and like there's this hush. And that's a little bit how I feel with my guest today, Dr. Keith Berkowitz. When he brings up certain topics, that's things that, especially that I don't even know about, I kind of stop and listen and want to hear what he has to say. Dr. Berkowitz is currently the medical director of his practice in Manhattan, the Center for Balanced Health. He was formerly the medical and business director for the Atkin Center for Complementary Medicine. He's the author of two books, The Stubborn Fat Fix and The Complete Idiot's Guide to Flour-Free Eating. Besides his medical degree, he happened to, in his spare time, get an MBA from Columbia Business School, quite a prestigious place. And finally, something we're going to get to today also, I think people are going to be interested in, he's part of the frontline COVID-19 critical care working group that have put forth novel treatments for COVID-19. So it is my pleasure to introduce my colleague, my friend, and even actually my neighbor, Dr. Keith Berkowitz, to the podcast.
Thank you so much for having me. Boy, you put a lot of pressure on me with E.F. Hutton to begin with. Huh?
Yes, that's what I like. I like to keep the pressure high. So the first thing I want to discuss, Dr. Berkowitz, is because I think people still have a lot of fascination with Dr. Atkins. So we can start with that a little bit, if you don't mind sharing. He was sort of this mythical figure in medicine, the diet guru, celebrity doctor, blockbuster businessman. He had a whole industry of Atkins meals, books. What was he really like? I mean, you worked at the practice with him before he passed. Was he a real innovator, a real student of medicine? I mean, what was your thoughts about him?
What I really loved about him, I always think about, we talk about, especially on this day of the pandemic, about how certain doctors distinguish themselves, who go against the grain and say, hey, listen, think it a different way. And he was one of the early ones to do that I saw. He was never afraid to say what he felt and what he meant. And he always backed it up with scientific evidence.
He did.
So back in those days, and no one could probably imagine today, a low-carb diet was heresy.
That's right. Right.
It went against everyone's. You couldn't do that. You're going to end up with kidney dysfunction.
Right.
Everything would go bad. I remember one of my favorite, things I remember is when I started working with him, we sent a request to present at the American Dietetic Association, and they turned us down because they said you can't do a low-carb diet. And now fast forward almost 30 years, it's probably the standard of care now, right?
Yeah.
Low carb diet, the keto diet.
Yeah, for sure. Yeah, that is definitely what's in. We're going to talk about some diets because I know that's also in your expertise. What I found though interesting about Dr. Atkins, just looking, when I remember always looking at his bio, he was a internist. He trained as a cardiologist, actually at the same institution where I did, St. Luke's Roosevelt in New York, which is now Mount Sinai West. How did he pivot to holistic medicine? Do you think it was just his interest in, different areas of medicine, besides just being a cardiologist?
If I remember correctly, I think he began in occupational health. So
Really?
One of his first things, I think it was occupational health. And he ended up meeting one of his mentors, which was Carlton Fredericks. So Carlton Fredericks was a famous nutritionist, probably in the 50s, 60s, and early 70s, who actually ended up later working with Dr. Atkins at the Atkin Center. So I think that was one of his big mentors. What's so interesting about Dr. Atkins, and I think most people don't realize, even though he was famous for diet, his true love was integrative medicine. That was
I
his
think that's a
passion.
good point. Well, I want to get to that because that's like a perfect segue because here he was again. From what I knew as an outsider, he became this successful quote diet doctor. Again, that's and then I started hearing about his practice, and it got obviously word got out. He was doing a lot of quote, I guess, very controversial treatments for that time: chelation, IV vitamin therapy. What both of us do now, which is routine. Ozone, which got him into a little trouble. I mean, and again, because it was so
Hypothermia,
radical.
hypothermia, which now he did hypothermia for prostate cancer, which was now even done for sepsis. So
Really,
yeah, he was
yeah.
doing a lot of
So he was willing to sort of really go out of his comfort zone. When I assume that he was a thorough guy, that he felt he had the literature or he had some experience working with other practitioners in doing this.
Yeah, he also, people don't remember, he got really badly beaten up. He even got called before Congress
No, I
to defend
know. I know. I
himself.
know.
Yeah.
No, the ozone therapy that I remember being in the paper. I think they suspended or took away his license, and it was a whole big thing. And here he was, this amazing doctor, and at the height of all of the, I call it the witch hunt, when they were going after doctors every single week, especially in the holistic functional community. And he was definitely the biggest target. He had the biggest target on his back for sure.
And he probably was one of the few survivors. If you look at the end of the
Yeah.
day, he
Yeah.
was able to weather the storm.
Yeah. They
And
wiped out a lot of
actually,
people. Yeah.
what I had so much respect for him is he never wavered. Like, no
Yes.
matter how much pressure he had and how many threats against him, he never
Mm,
stopped believing what he thought. And what's interesting is everything he ever did, he took from literature.
right.
We'll even start with the low carb diet. I remember him showing me an article in the JAMA, in the Journal of American Medical Association, from the 1960s on
Mm,
low carb diets. Even further back into the 1930s, there was
wow.
studies on the Inuit Indians that were being done. So he actually took from literature. And what he was, in my mind, famous for was intravenous vitamin C, which he took from
Really? Oh, I didn't know that. Wow.
Linus Pauling. So,
Yes, right. Sure, of course. Yeah, he was one of the
only won two
heroes.
Nobel Prizes, not too famous.
Yeah.
And what actually attracted me, and I'll tell you the story how I ended up working there,
Yeah.
is I went there to visit, and he had an intravenous room, IV room at the time. So I
Right.
went in to talk to patients, and I met three women. All three had breast cancer, and all had told me that they were told by the doctors, write your will, pack your bags, you're going to die within 6 months. And each one told me that was 15 years ago.
Wow.
So he had kept them, going with this intravenous vitamin C. And, so interesting, we'll talk about this later, is that's really part of the treatment for COVID.
Well, yeah, we're gonna get
19.
into that. Yeah, I know. Well, that
And
you really, yeah.
it's so
Well,
interesting.
you're right because we had Paul Marek on the podcast several months ago. We're definitely gonna get into that, and it was interesting how you have a connection with him. So, my final question with Atkins, because now we're gonna get to you, because Dr. Atkins, he's history. But what would you say you learned the most, or you admired the most about him? If you had to sort of summarize it.
So this is going to be an interesting thought. So to me, it was sitting in front of him with a patient,
Okay.
and him not knowing something, opening the textbook and looking it up while the patient was present in front of him.
Wow. Right.
That to me,
Remember, this was before Google. Right now, if I don't know something, I ask the patient, pause, and I turn around and I Google it. I said, let's look at it together, and hopefully I can give you, some insights.
Well, you and I grew up
Okay.
with an Encyclopedia Britannica, remember? So
Right.
that was our,
Right.
and thank God they had a supplement every year. But to me, you remember at this time, he was probably the most famous doctor in the world,
Yeah.
arguably.
Oh, yeah.
He had the courage to show a patient that he didn't know something and look it up. That to me forever stays with me.
Yeah, so that's incredible. Yeah, I mean, essentially saying his humbleness to not be so arrogant, because we hear so many stories. You and I both, patients, with the patient brings up something even to the doctor, and the doctor just waves his hand and says, that's ridiculous. Candida yeast, that doesn't exist. IV vitamins, they don't work. And they dismiss the patient, not really even knowing anything about these treatments or diagnoses. And so that to me is pretty impressive. So you just told me in a nutshell. I unfortunately never got to meet Dr. Atkins, but I would have liked to. So, but you're my connection to him. All right, so let's get to the Center for Balanced Health, and I'm going to ask you something interesting. Okay, so I remember, I think you told me too, you discovered unfortunately Dr. Atkins when he passed away in his office or something. So all
Yes.
of a sudden now it's your practice essentially, right? You're taking
Yeah. So
over.
actually, I found him on the street. He had
Oh gosh,
fell on
he's
black ice
wow,
and hit his head, and unfortunately never woke up.
wow.
And then after that, I actually within a month founded my own practice. Actually, we ended up starting in Gramercy. I was able to get an office space from a colleague of mine.
Oh, so you left? You didn't stay in the same space where he was?
No,
I didn't
no,
know that.
that practice ended up closing,
Oh,
and we opened
wow.
up a new one.
Okay.
And but I was lucky. I got to take the best of the staff with me,
Oh,
so I
that's
was very
right.
lucky.
Well, I was gonna say, so at that point, I mean, obviously you knew his protocols, his way of doing things, but now, like anybody, when all of a sudden now the ball's in your court, you're kind of, um, making your own way in your own path. So, what do you at your practice, when you call it Centered for Balanced Health, why do you use that term, and what are you trying to achieve with the patients?
The reason I chose the term balanced, and I think you and I we talked about this before, is my background's conventional. I trained in the hospital. I
Right,
worked as a hospitalist.
right.
I maintain hospital privileges even till today.
Mm-hmm.
And to me, balance is taking the best of what we call, what they call, people call conventional, and the best of what they call holistic,
Right,
and create that, what I use like the term integrative, to
right,
use the best of all treatments. And
right.
I think that's important. I think we shouldn't ignore one way or the other, but we should take the best of the information we have out there and form the best possible treatment plan for your patients. And I think people really appreciate that, and allows us to communicate effectively with their own doctors and really help them, get the best care possible.
I agree with you. The story I always tell patients is this. Again, I deal a lot. Yeah, I think with candida, which I found fascinating. I knew nothing about it 10 or 15 years ago, and now it's the bulk of the patients that I see in my office. But they're very interesting cases, when you don't, it's funny when the light opens up and you finally are seeing it, that so many things make sense. But exactly to your point, I tell patients a couple of things. One, obviously, they can get a lot of information on for example, candida on the internet about the yeast-free diet and all that. They don't need a doctor for that. And on the other hand, and a lot of them sometimes go to health food stores. And I always tell them, because I know even locally where I have been on Long Island, there have been some very good health food stores. They have some pretty educated people. But, and this is the big but, I always tell them, but that person in the health food store doesn't know your iron level. They don't know your,
I love, yes.
your blood cell counts. They can't prescribe antifungals if you need them. So exactly to your point, again, I think having the combination is a potent prescription for the patients and a benefit. And I know yourself and myself, we've had people come from out of state because they couldn't get the kind of care, the combination. They could only get conventional, or if they were going holistic, it was somebody who wasn't a medical doctor that could actually still prescribe medicine or do diagnostic tests.
My favorite quote from a patient, I have a patient that comes all the way from Port Jefferson family to see me in the city.
Or Jefferson, you have people
And
coming from the Middle East to see you.
no, but he gave me the best quote.
Okay.
So what he said to me is like, someone asked him, why do you go all the way to the city? There's great doctors out of Long Island. He goes, I can't afford not to go see him. So
Yeah.
the point is that
Yes.
that's what's kept him healthy. You know what also I've learned, and you've probably learned this over the years, is I've learned that I've gone from where I was trained from a top down model, right, where we look at symptoms and stuff, to more of a bottom up. And what I really learned, that the disorder may not matter as much because the foundation is often the same. So a
Right.
lot, like, and I think that's where someone going to a health food store is going to miss. Like if they have candida or something else, their digestion, their blood sugar, there's so many interactive processes there that you have to be able to look at all of them. And I think, when someone just seeing a small picture of it, they may be missing the whole picture,
At
and
least
people
makes
may not get better.
that was a great, again, another segue into the question I wanted to ask you too. It's very interesting. I order certain blood tests that not a typical conventional doctor does, that I think more functional medicine doctors do. I see labs from a lot of times other doctors that, patients have switched care. Actually, I've never really seen one from you. So they like you a lot. They don't leave you.
I'll
But
send you some if you want.
no, no, it's okay. We could just talk. But what tests would you say? Because I'll throw out a few of mine after if you want. Like, what tests do you think should be part of a more routine assessment, even of a patient? I'll throw out my things like I like to look a lot at homocysteine levels. obviously magnesium in the red blood cells, things like that, and iron and ferritin levels, which, I find that a lot of times people's general doctor don't really focus on it at all. Like, and, and again, but the holistic doctors sometimes, or functional medicine doctors, too, they order a lot of amino acid studies and things. And I look at them saying, I'm not sure that means that much to me. So I'm curious, what would, out of your typical chemistries and CBCs, what do you like to order that you find has, high value?
I like homocysteine. I do ferritin. I
Yeah,
do now vitamin C, vitamin
you
D. I
do.
do magnesium.
Well, when they say
Yeah,
like or glutathione, do you find those levels are reliable and give you a good idea of how someone's
not always. I mean, vitamin
no?
C is kind of interesting. So in the age of COVID, I'm definitely seeing that low vitamin C post illness is leading to more likely to be a long hauler. So we start to
Really?
see patterns. But to your point before, I thought about the labs you stated to me. You know what I thought to myself? Liver function. So like if you're treating candida, you have to make sure the liver works, right? If your
Right.
body can't detoxify, then you can't get rid of the candida, right? And
Right,
that's
but
always think
many
of.
times the liver function tests are normal though, so that's what I'm saying. That's why, and people are always concerned about glutathione and milk thistle to help the liver function.
But I look at ferritin. So ferritin is
Ferritin's
another
a good
marker,
judge. Yeah.
yeah, of where and people forget about liver function, and this is always interesting. When typical liver tests, you need to have like 80% damage to have high levels,
Right. Right.
right? So
Right.
you're not going to necessarily see that. And what I've also learned, and you start talking about tests, is, and this has been the hardest transition for me from when I started my training, is to be able to take a step back and not look at each individual part and test, but how they work together. And that's where the interesting thing becomes, where a normal level may be okay in someone, but when combined with other tests, it may not be so normal. Let me give you
Okay.
my favorite
Yeah.
example
Give
of
me an
that.
example. I'm thinking like how
With cholesterol, a
yeah.
high HDL.
Right.
So a high HDL, say someone has
That's a
diabetes,
good
for
thing.
example,
Yeah.
right? No, but in a diabetic, HDL should be low. So if an HDL is high, I use the term discordant. It
Mm-hmm.
means the adrenals may not be working, digestion may be off, thyroid
Right.
may not be working.
Yeah.
So the HDL is inappropriate for the person's other issues. And that's what I kind of look at.
Let me ask you. You bring up a great point because sometimes this thing can be very confusing. I mean, people we know now also where hemoglobin A1C we know is an important marker. I mean, this seems a lot for anti-aging or have your blood sugar control. But I've had a patient I've been following for a while. It's really interesting. She's always worried because whenever we do her fasting glucose, it's about like 110, which obviously is not great. But her hemoglobin A1C is 5.3, which is low. How could that be?
If
Is
they're
it?
very insulin resistant, they're having a lot of volatility. So people that are
Uh,
very insulin resistant, what it means. See, I like that. That's my example of discordant. I love
Yeah,
that
that's
word.
why I brought it up. I was, I want. That's why I like talking to you. Like I want the listeners to benefit. It's like I once in a while I get these bloods, which I'll see not often, but enough that I'm like thinking, wait, this doesn't make sense.
But to me, that's more worrisome, right? Because the average
Well,
is
what's the worrisome
normal.
part? The high
The
glucose,
volatility.
the
So if you're having
volatility.
a high fasting, then it
Yeah.
means you have to have low numbers to make up that A1C. So the
Uh-huh.
volatility, and I find from a
Hmm.
complication standpoint, especially in people with blood sugar issues, volatility is really critical.
So what would
People
you
with
do for just? I mean, I know you don't know the patient, but what would you do for a patient like that? You would try obviously, and they say, I know this patient actually. She's lovely. She follows a really clean diet. And she really watches her sugar. What would
What
you?
about stress and cortisol? So
Well,
that's
I'm sure
another
that's
factor.
yeah. We live in New York, Dr. Berkowitz. This I don't have that thing. I don't have in my drawer that shot that gets rid of stress. But
Yeah, a needle drain cortisol out in the morning. But what people forget
so
about blood sugar.
would you look at that then? Okay, that's
Yes, absolutely.
so
Because
okay. So
people
you would get
forget,
a morning cortisol, or would
and
you do
probably
when the
nighttime as well
saliva?
too. I would do probably
What
a
about the
4.
saliva? Do you find that,
Yeah.
that's another great point too? Like the saliva test, I've ordered a lot of them over the years because I think as you do too that the adrenals are underappreciated. There are stress gland. Obviously we know so many of our patients are stressed and it causes God knows how many issues. But I have been frustrated. I do like ordering an AM cortisol level and along with aldosterone, just to get an idea of what's going on in their adrenal glands. But I've ordered a lot from, I guess it's Genova, the saliva that measures the cortisol and I think DHEA.
Hmm.
Um, Never found it to be like really off or give me any kind of clear cut thing. Do you
Well,
you find it
yes,
useful?
I'm not looking necessarily always a high or low. I'm looking at inappropriate.
The
So
the
let me give
graph,
you
you mean the
example.
way it's
Yeah.
swinging?
Let me give you an example. So someone who's very highly stressed and they have a normal cortisol in the morning,
Yeah.
that's probably not a good thing, right? That means they're not responding properly.
Mm-hmm.
So, or if they have a high cortisol at night and they're not sleeping, that could be the reason. So it's
Yes.
really
Yeah.
also, see, that's where I find where medicine, where a robot can't do medicine, right? So that's where intuition and experience teaches you, because the
Right.
labs could still be normal,
Right.
but they could portray a picture that's abnormal. And I think that's really critical that we have to always look at.
Okay. All right.
And I use the term discordant, inappropriate, things like, for example, you can have a normal glucose and insulin level. The glucose level could be 75, which is still normal, but the insulin level could be 20, which is normal. But someone with a glucose of 75 having an insulin of 20 is really abnormal. It's
Right.
really way too high.
That's a really good point, right? Because they don't really teach you that in medical school. It's like
No.
and of course now today more than ever, doctors look at, they like you wrote that book about the Idiot's Guide to Flour-Free Eating. It's like they've done with labs now, the Idiot's Guide to Reading Labs. I mean, you and I both know too. I mean, I have to do two things when I have a patient come into the office. Especially even with COVID now. What I do, before I used to sit next to a patient and actually go through, a hard copy of their labs and show them, they'd see all these abnormals because, the lab keeps on changing the ranges. So they see all this blue or red and they get nervous. And, what I tell them right off the bat is I said, look, I said, anybody can read a lab that says abnormal, high, low. I said, it's my job as a doctor to carefully interpret, because my best example is you could be off, 20 points on your liver test. It's not going to make a difference. But if you're 2 points off on your potassium, you could be dead.
Right, exactly.
Right. So, but I like what you're saying, that, really what doctors don't, and I think they're not even trained enough to say, what's the relationships between these abnormal, not just say, oh God, this pancreatic enzyme is up, that boom, just start running in that direction. Let's get an abdominal scan, do this. What is going on with all these other related tests? So that would be like an interesting course in itself.
But you know what I think what's happened is I think we've forgotten like basic, biochemistry, basic chemistry, basic biology. I think it's almost like, it's funny, we learn in medical school the first year, all the basic sciences. I think we have to have a refresher at some point.
Yeah.
Because people are forgetting that.
What? You're right. It's funny because, you think back, and I tell this to the medical students when I teach them at Thoreau. I tell them, because I teach them in the first year or two, I teach the basic immunology section. And I said, really what you're learning your first 2 years of medical school is a foreign language. You're learning like all these terms.
Absolutely.
You're not learning anything practical in most of the cases yet, because you got to be able to speak the language once you start really, once they throw you into the country. And but I think you're right also that, again, when we get I find myself too buying books that were like kind of medical school kind of books to refresh myself. Like you said, Linus Pauling, he was like really the ultimate, functional medicine doctor. Even though he didn't practice, he wasn't a MD. He knew those pathways. He discovered those pathways, that our cells go, and has so much to do with, mitochondrial support, things that also you and I see with chronic fatigue patients, and trying to explain to them how we have to boost their mitochondria, why certain things like magnesium and things that can boost ATP are important. But if you say, oh, I learned, about ATP, I always tell patients, I said, especially my chronic fatigue patients, so I said, look, we got to go back to 8th grade biology right now. So you with me? And then they get that little scared look on their face, like, well, I didn't do so good in biology. I said, it's okay. I did all right. I'll explain it to you.
Well, look at like a virus, right? I mean, if you ask people where a virus goes, how a virus replicates, how a virus works, people don't know. And when you think of treatment, and I think this is what you and I have learned, when you think of treatment options, you need to know how things work. Yes. We talk about chronic fatigue. You need to know how the Krebs cycle works, right? Because that's where we're looking at. And sometimes sometimes people call chronic fatigue viral encephalitis, where it affects the brain. And some people now thinking post-COVID may be some of that too. Then you have to know how to get the body to work better, how to get the immune system to work, how to get the digestion to work. All these things really work in concert. And I think one of the problems, we've become too specialized, where we lost some of that.
That's right. You're 100% right. Nobody wanted to move out of their comfort zone. I mean, it's almost like Dostoevsky said in, I don't know, one of his quotes, because I think he was a doctor or an engineer in Russia, but he said, he goes, one day the doctor will be examining the person's right nostril and will say, I can't examine your left nostril. That's not my area, you know.
You can only have one billing code today.
Yes. We're going to get to that too. I'm telling you, we have the full thing here. Okay, so let's move on. Okay, well, and one last thing too, I want to say to your point also is that and I think also like you're saying about patients understanding things. It's like, again, I also see a lot of chronic sinus patients, especially in the allergy side of my practice. And my biggest pet peeve or war has always been protecting my patients from taking antibiotics, because so many of these patients, it's been either just inflammation from allergic inflammation, or it's been fungal inflammation. In a lot of the cases, not bacterial. So all of these patients that have gone on antibiotics, sometimes for weeks or months, developed all of those secondary problems like candida or other issues from being on antibiotics. And I think if patients understood that, that viruses don't, or allergies don't respond to antibiotics, they wouldn't be demanding it or even accept it. Do you agree?
Well, that goes back to our foundational, right? So if the foundation's good, the immune system works good, you don't need, your body's able to fight it off itself, right?
It's
You
true.
don't need.
Well,
I mean,
that's
I
true.
think we forget
Right.
about that.
Yeah,
right?
well, right. And a great example of that too is that, and I tell patients, my biggest thing now is this lavage machine. It's like the best neti pot thing. You have the salt water in it too. You rinse through your sinuses. These people are like, oh my God, my sinuses are better. I don't need to take antibiotics
And look at the side effect profile, right?
I
I mean,
know.
that's what really counts the most.
Right. All right, we're moving along pretty nicely here, and I'm having a lot of fun. I hope everybody else who is listening is. Let's go on to, because I'm fascinated, this how you got into this COVID-19 frontline working group. As I said, I was, the thing that the light bulb that went off in my head when I spoke to you several months ago was like, I followed the literature and I was like, Paul Marik, interesting guy. He's been writing these articles about IV vitamin C for sepsis, and he's a pulmonologist. He's not one of these flaky functional medicine doctors as we get sometimes labeled. He's a serious doctor in the hospital. And, when you happen to mention that you were in this COVID working group with Paul Marik, the light bulb was like, Paul Marik, yeah, he's been doing this. So tell me how you got involved with this and why you got interested in it.
So it's a great story. So it all started, I couldn't sleep Wednesday night in March. COVID had just started coming out. Mm-hmm. And I'm like, there's got to be something better that works.
Okay. Yeah.
And what happens is I started doing some research. I was looking for, some of the more severe treatments for sick patients. And right. I felt, okay, let me look at the ICU literature, right? I figure if people are dying and they get intubated and stuff, there's got to be something there. And I found Paul Marik's studies on sepsis and septic shock.
You did, right.
Mm-hmm. Yeah. And he used a protocol he called IHAT. So it was hydrocortisone, ascorbic acid, which was vitamin C, and thiamine. I'm like, wow, this is right up my alley. And so I called him. And I started talking to him.
You're like me. I call people randomly. They think I'm like, what am I selling? But yeah, I like that. Okay.
Thank God you didn't hang up on me.
Right.
Actually, the secretary picked up first and called me back.
Yeah.
So I started talking to him and we started discussing, and I read more literature. I found, he had been criticized for his study by this vitamin study. And citrus ali.
A lot of heat.
Yeah. And what people don't know about Paul Marik, he's the top intensive care doctor in the United States.
You think so? Yeah. I mean,
from a research standpoint, he has more publications.
Wow.
From citation, he's number 2 in the world behind one.
All right. We have to pause for a second. Please, everybody, listen to my podcast on IV vitamin C with Paul Marik, which I did several months ago. If Dr. Berkowitz says he's the top, I'll take his word for it. Okay.
So and I looked at, and in Chicago, they did a study on pediatrics and they reproduced his results. His results showed an 80% reduction in mortality.
Wow.
I mean, that was.
People should only know sepsis. We know when we were in the hospital and a patient had sepsis, that was like a death sentence. I mean, I don't know what is like. It's like a 5% survival rate.
Yeah, and he had and so I ended up talking to him. I'm like, any other doctors think the way you do? He gave me a couple of the names. Joe Verone in Houston, I talked to. Humberto Midori in Tennessee, Pierre Corey, who's now the most famous one after his Senate testimony, poor guy, in Wisconsin, and Jose Iglesias in New Jersey. And we ended up really liking each other. We ended up forming a group. Howard Kornfeld, who's out in San Francisco, was really good and making us into a group. and we ended up forming this we call FLCCCC, and we decided there's no treatment right now. Actually, you know what's funny? Even today, there's no treatment protocol for COVID.
You led me to my next question. I was going to say, because Dr. Berkowitz, let's say look, Paul Marik, again, on my podcast too, opened my eyes. I mean, Governor Cuomo, the country, everybody was desperate. Let's get these ventilators. And now we're finding out this is like really bad news. You go on these ventilators, there's a good chance, unfortunately, you're not getting off of one. And Paul Marik brought up about the low flow oxygen, obviously doing the vitamin things, because Dean, you won't need to do this, which
Right.
God knows, you're on a ventilator for a month. You're lucky if you'll be able to walk in the next 4 months, even if you get off of that. So let me ask you this, Dr. Berkowitz. You get a patient, I mean, it's rampant now. You get a patient in your practice that calls and says, I just tested positive, not feeling so great. I'm not, I don't know how sick I am. What are you telling them to do?
So that's changed in the last 2 months.
Okay.
So maybe what I'll do is I'll talk about his protocol, and then I'll talk about how it's changed.
Yeah, right. Now. Okay, right. Because I had done that before, but I want to hear. Yeah, because he had a whole list of his vitamins, which you'd share.
So we had an individual protocol called Math Plus, which is a combination of methylprednisolone. What was really interesting, we found that ascorbic acid, of vitamin C, thiamine, and heparin. What was so interesting, and I didn't even know this, that methylprednisolone and vitamin C are synergistic together. They really are really powerful.
Wait, let me slow you down on one thing though too. This is important because actually maybe, and I don't know, even doctors listening to this might be a little bit confused. Okay, so Dr. Marik did work with hydrocortisone. Obviously, that's one form of it. I've been seeing a lot in the literature. They're saying now dexamethasone is better, and I think you don't agree with that. And methylprednisolone, that's another form of cortisone. So the
reason why methylprednisolone is superior is its lung
absorption.
Exactly, it's so much greater than
but that's oral. Actually,
no,
methylprednisolone is IV and oral. What?
Yes, and what turns out that methylprednisolone has greatest absorption within the lung of any of the steroids of the corticosteroid.
That's really important to know. I didn't even know that. And I treat asthmatics, and I mean, I guess that's why. I mean, that's what Medrol is, right? Those Medrol packs that people get. And okay.
So that's why we would choose methylprednisolone over the other ones, even though the original studies were on hydrocortisone. We've learned, and this is Dr. Maduri's research out of Tennessee. Yeah. He's really the expert on it. That the greater bioavailability and efficacy of methylprednisolone in lung tissue. And again, remember, people are developing viral pneumonia, so that's one of the reasons what happens. What one of the problems early on, you talked about the ventilators, was that people were developing blood clots. They were becoming
right. Well, this is like a vasculitic type of viral infection. Right. It's not a lung infection. It hits any blood vessels, which obviously is cardiac, kidney. I mean, that's brain. I mean, this is why it's such a damn deadly.
And the problem with using ventilators in someone with blood clots, you're increasing the pressure.
Right.
You're going to cause more lung tissue death.
Right.
So it actually, and then make it much harder to get off of a ventilator from that aspect. Yeah. So we early presented that in March. Government.
Did you say you presented it? What did you do? Was it published?
To government, we tried to publish it.
To the health officials?
I spoke to, you name it, every politician you can name. And, and we got dismissed until later around August, when the recovery trial came out from Oxford showing dexamethasone worked. All of a sudden, steroids are now the standard of care.
Well, no, okay. Now, when you're saying it's working too, are we talking about hospitalized patients, or would you
hospitalized patients?
Okay,
yes.
So right. Okay, so you're going to take me through how you deal with somebody who just, unfortunately found out we're having a lot of people having positives. What they would do, and then obviously we'll talk about the hospital stuff. So what would you do? As I said, you get a patient who calls you and says, "I'm positive. I just tested positive. What should I do? Just sit home and wait it out?"
So we actually have a new protocol called iMask.
iMask?
Yes, iMask.
Okay.
So what it is really it's led by a drug called ivermectin.
Okay.
So ivermectin, a lot of people may not know this drug, but it's probably the most used drug in the world today.
That's the anti-parasitic medication, right?
Right. Yeah. It's been given 3.7 billion times.
Wow.
So it won the Nobel Peace Prize, the drug and the inventor, Dr. Mori from Japan, because of the amount of lives it saved in Africa.
Wow.
Pretty much and what's interesting, it's really considered a drug at the level of penicillin or aspirin. I mean, if you think of from drugs that have so many uses,
right,
in so many different fields, aspirin and penicillin have been found, like super drugs, right? They work on so many different things.
Right.
Ivermectin is at that level. It works on so many, from head
So wait,
lice.
so just so I'm clear. So ivermectin, from what I remember, because again, I have infectious disease training stuff too. That was used for parasitic infections.
Right.
It's
Head
also used
lice,
here for, isn't it
scabies,
used here for scabies? Yeah, it's used here for scabies.
and head lice. Yeah.
Right,
Yeah.
right. So it's usually just a couple of pills. So just out of curiosity, whoever discovered, like, who made this connection to COVID now, and why should an anti-parasitic medication theoretically work? Does it work on blood clotting? Does it work on, what's its mechanism that
So it's interesting. So the connection is actually not new. So they've actually thought for a long time that it has antiviral properties. They've been looking at even things like Zika, influenza, that it has an effect on those, dengue fever. So it
Okay.
has, other viral properties. What's interesting, what it does is it blocks what we call a cargo transporter protein that
Okay.
allows the virus to enter the nucleus of a cell. What I think people forget, and this is back to, early cellular biology, is that in order for a virus to replicate, it has to get into the nucleus of the cell.
Right.
So it stops that process. So in vitro studies, it shows a 99.8 decrease in viral load within 24 to 48 hours.
So, okay, so let's, if I could be a little specific. So let's say again, you get this call
Sure.
from a patient and they say, Dr. Berkowitz, I have a little low grade fever and I don't feel terrible, but I have the virus. I'm worried. You would start them on ivermectin.
Yes. So the way we do it is it's given 12 milligrams. It's a weight based, but roughly 12 milligrams on day 1 and day 3. And that's it.
What do you mean?
For that drug.
You skip day 2?
So day 1, when you first
Yeah.
treat them, and then 2 days later, you give a second dose.
Oh, you wait. You mean because it has long acting? You don't have to give it the second day. You give it the third day.
Yeah. So it's about 48 hours.
And that's it. And that's it.
And that's it. Actually,
But
I just
for
got
the
an
ivermectin
email today on the ivermectin. I got an email from a doctor in Los Angeles in the hospital. She's been doing it. She did it on her first 5 patients. All 5 recovered. Normal oxygen.
So let me ask you the big questions here too. Now, I don't know. I don't remember if we talked about it back then too, but again, remember the hydroxychloroquine got obviously all that attention as a preventive, this and that too. Seems not to have panned out. I don't know. Do you still agree or disagree with that? And, I guess we just, as I said.
Well, hydroxychloroquine, it's more, there is some effect in mild disease, really, as an outpatient drug. It really is not shown to be that great as an inpatient drug.
So that was the problem. There's that it was inpatient. Okay.
But also remember, ivermectin is actually a direct antiviral. So that's the difference, right? We're looking, so ivermectin has an antiviral effect. That's really what we're looking at. So it's not as an anti-inflammatory alone, but it seems to may have that as well. And I'll talk about long haulers too. There's some effect on that as well.
Now, you mentioned to me too before when we had met that that you're getting a lot of pushback about this though too. That was, I don't know if is it big pharma, is it big government? Who is like not happy about this? If
did you name probably everyone? No,
really?
Actually, what's interesting is
why
a lot of the studies have been done outside the U.S. And what's interesting, we've seen studies from Bangladesh, Singapore.
Yeah.
I got an email from a scientist in Iran.
Wow.
That's the first time that's ever happened. Peru, Argentina, Egypt. There's been Iraq. There's been studies been done, and a lot of them are smaller studies.
Right.
And also this anecdotal stuff, right? Look at Africa. You don't really hear about, except for South Africa, much COVID in Africa, in most of the continent of Africa. And that's also we're seeing too. So there's anecdotal evidence.
I thought there's that new strain now that's like kind of going through there, but
South Africa.
South Africa. Okay.
South Africa is considered a little different. So and what's interesting, but though there are hospital systems now using it, University of Alabama Birmingham is using it. So it's starting to gain some traction.
And are you using it with anything else? I mean, along with the vitamins, I know that you've recommended before, like so with vitamin C and B.
So the vitamins So I use vitamin D. Should I go through the action two of each?
Yeah, let's go through this. Let's go through this a little bit. I think
so. Vitamin.
Yeah.
So vitamin D we use.
How much do you use? About 4,000.
Quercetin.
Yeah.
So vitamin D with prophylaxis, it's 2,000. And by the way, ivermectin may work for prophylaxis as well.
Okay.
And then for early treatment, we may go up to 4,000. For vitamin C for prophylaxis, it's about 2,000. And then for treatment, about 4,000 to 6,000. And next one is quercetin, which is 250 milligrams, and then up to maybe 500 for treatment. Melatonin, interesting enough,
Yeah,
which
he
people
talked about
use
that
for
too.
sleep a lot,
Yeah.
can, between 6 and 10 milligrams going up. And for early treatment, if it's not contraindicated, aspirin, a full
So
aspirin of
you,
325 milligrams.
so you don't have any clotting. Okay. Makes a lot of sense. I mean, and obviously it's easy enough and not that expensive. I mean, it's sad that again that nobody really gives people any guidance because most of the times, people like just go sit home and wait. Keep your pulse ox if you have one on. Just make sure.
Well, what's interesting today, there's still not a guideline. And actually, it's just been recently again presented to the NIH, waiting for them to look over the data.
Mm-hmm.
There's 30 randomized controlled trials that have been done already. I'm waiting for one of the biggest out of Singapore, which they looked at 4,000 people,
Mm-hmm.
which is one of the biggest trials. That's currently in peer review.
Mm-hmm.
So we'll have to see what that shows. But what was the most dramatic of all the research that I saw was in Argentina, they looked at healthcare workers, and they gave 800 people ivermectin prophylactically, and they had another group, the control group, which didn't get ivermectin, which was 400. In the 800 group, 0 cases of COVID.
Well, let me ask you this: so prophylactic, how long would you have to take it? Because you said you're only taking 2 pills. You would.
They would do it. I think prophylaxis. Some studies were once a week, some were once a month.
Uh-huh. Okay.
And
And as far as no real resistance, because with antibiotics, we worry about resistance, even antifungals, we have to worry
but it's
about.
actually not working. It doesn't work specifically on the virus. That's the difference.
So that's why you're
it's
not getting.
blocking the carrier protein.
Okay.
So So what's interesting about ivermectin, the virus may not matter.
Okay.
That's the beauty of it, right?
Yeah. Okay.
It actually is blocking the mechanism.
Yeah.
And
I think also Paul Marek brought up, and maybe you did also, like, it's interesting why zinc, or they mentioned too, why they think also zinc is a good supplement to take because that also blocks the virus from entering.
Yes, specifically RNA viruses too. So zinc is very.
Yeah.
And ironically, things like Zithromax, where they sometimes use, or hydroxychloroquine, work through a zinc pathway.
Same way too.
Yeah.
Interesting.
So what's interesting, so in that group that didn't get the prophylaxis, 58%, or about 237, got COVID. That's pretty dramatic.
Yeah, that is. That's, boy, these kind of things, to get this epidemic, pandemic.
What's so disturbing to me is here's a drug that's known, right? It has a long-term safety.
Right. I mean,
knowledge.
I feel safer with that than I do with hydroxychloroquine. I got to be honest with you. I think, I mean, as I said, I've used ivermectin for scabies. It works great.
And its safety profile
is awesome. It's good.
And
really
its
good.
safety profile is well known. It's low cost, and we need to try something. I mean, I think waiting and watching is not an appropriate.
Yeah, it's not right. That's not, that's not, it's like with food allergy. I've talked to you about this before too. I do these sublingual drops for dangerous food allergies because I finally jumped in because the literature was there. It's shown to work. A good colleague, friend of mine, David Edward Kim in Duke, now in North Carolina, has shown it works. It's like sitting on the sidelines, not an answer anymore. Like, to tell people to avoid when they have like 5 major food allergies and they can't go out to eat anywhere. It's just not a life, it's, it's like us with COVID. We're boxed in, and people want to get out of the box.
You know what this drug cost?
I pay you $3. Well, I should say that. I would say $3 a day.
Yes,
but, yes. But if one of the hedge funds gets a hold of it, it could go to $1,000 a day. That's what I worry about. So we better keep the secret.
No, it's
among
generic.
our listeners.
It's generic. By the way,
yeah, I know, but they do that. They do that to everything.
It's actually given away free. Merck gives away 600 million doses every year.
Do they?
Yeah, they ship it to.
Well, thank God Merck owns it.
If
it was a smaller pharmacy, they'd be bought out by. We're going to get into this. Why healthcare is so insane. Couple of things too. I mean, I'm just curious. What do you think about the vaccines? I mean, don't you still think that they're? I mean, I'm a big believer in vaccines. I think they're very important.
I like to. You know what it is? What I'm a little nervous about. There's been a death this week. I don't know if you saw. A doctor died in Florida.
Oh no!
2 weeks after
an allergic reaction, or they don't know.
Autoimmune thrombocytopenia, autoimmune platelet disorder, and ended up having a stroke.
From the
what
vaccine,
my concern is because the new tech. Well, they don't know. It was 2 weeks. Healthy guy.
Yeah.
So what I'm worried about is people with allergies or autoimmune disease. That's where we don't have really clear literature on.
Right.
To see what the risk is. And again, there's other vaccines coming out like AstraZeneca, which may be more traditional, which may not be as problematic for that group. So that's the one group I really kind of worry about right now without knowing more information.
Interesting.
And they now in the UK, they warn people with allergies not to take it. the
Yeah,
5-FU.
well, I guess I should address that too. I'll tell you my input on that because again, my background in allergy, I gave it a lot of thought, and I deal a lot with what's called mast cell activation syndrome, which I think has been an underappreciated condition. So yeah, I think the U.S. was a little bit cavalier. I think any patient that has, and we all know those kind of patients that have these extreme allergies that just like everything they seem to react to, medicines, vaccines, some of them foods. I would be very, very cautious and, have to weigh in the risk benefit because I just think they have overactive mast cells. And mast cells, as I did on a prior
Right.
podcast, they're your patrol cells. They're like the first line of defense, and anything can set them off. So I think for our
Well,
hope,
these are people that are not taking other vaccines, like they're not
yeah,
taking the influenza
right.
vaccine
They
for the
don't do
same,
well. They,
for the
the
same
ones who
reasons.
everybody used to think they were crazy. They're not crazy. It's, their body just doesn't handle these things well. And, but I still also make the analogy. It's kind of like the polio epidemic that I think the only way we're going to really get out of this thing, to some normalcy is we can, have really, a high degree of the population vaccinated and hopefully safely because,
But I think you need to use both. I think you have to use the influenza model, which is Tamiflu and the influenza vaccine. I
yeah,
think that's the model we need
yeah,
to
that's
use,
true too.
where it's
Right.
an
Because,
ivermectin and a vaccine together.
yeah, I agree with you also. Like,
I think that's really important.
yeah, I've had influenza twice. I had the swine flu in 2008, unfortunately, and it was pretty nasty. And I had one of the other influenzas. They weren't. I was in residency, and they weren't even offering us vaccines back then. It wasn't like doctors were
But
treated
I
right.
wonder if I wonder if used together, you don't need to get as high rates to get out of this. That's what I'm really curious about, right? If you prophylax enough people with ivermectin and they're not getting sick, we may be able to develop immunity much faster. That's one thing that's interesting that we haven't thought about.
Okay.
And also, what's confusing, and maybe you can answer this for me, if you have positive antibodies, you get the vaccine. That's what they haven't made clear.
This is what they're putting out. It didn't make sense to me 100%, but what they're saying is that you should still be vaccinated because, which is very a little bizarre because they're saying they don't know how long the immunity is going to last. And, typically a natural infection immunity is usually a lot more powerful than a vaccine.
Right.
So I
Right.
don't know where they're coming up with that information. I know people are on both sides of the fence. People that have had and recovered and say, I don't really think I need this now, the vaccine. And I know other people are saying, look, if it, especially if they're healthcare workers on the front line, they're like, I don't want to ever get that thing again. I mean, it was just so nasty.
And the last group is the long haulers, right? I mean, what do we do with them?
Well,
and what's interesting about them, I've seen a lot of them have positive antibodies. But what's interesting, there's actually a study in ivermectin that was done in Peru.
Yeah.
And they took 33 people that had long hauler symptoms. What I mean, post-COVID symptoms, fatigue, body aches, headaches, blurry vision, and they actually gave them the 2-day, 2 different day treatment. 88% of them improved immediately.
Well, Dr. Berkowitz, this is really important information because, I
think we need to kind of delve into those groups because if someone has long hauler symptoms, is a vaccination appropriate if their immune system may already be hyperactive?
What do you think about the IV vitamin C? I've been using that in some of the patients for the long haulers. Do you think it may?
Yes.
Or is it too late, or do you think it might help?
Some people do. Steroids sometimes work. What's really interesting with IV vitamin C now, Dr. Verone in Houston, in really, really sick intubated patients, they've upped the doses to 25 grams twice a day.
Oh, wow. Wow.
And they're seeing response that the 6 grams may not have been high enough.
Well, then I'm hopeful that with the long haulers, that maybe, again, like the chronic fatigue patients I see, and you probably see in your practice too, I mean, I can't say it helps out everybody, but there's that percentage of patients that it's a game changer for them. And, this is, again, very murky area because I know a lot of them are being followed. Some of them
what's
being
also
followed
interesting,
Sinai, and they're not doing anything.
In chronic fatigue, I see a lot of POTS.
Yes.
POTS,
I did the thing with Peter.
Hypertension.
Yeah.
We've seen a lot of that too.
Which is interesting, right? Because it's somehow right. It's affecting the autonomic nervous system. All right. The last thing I want to get to, because
that's why.
Yeah, go ahead. No, go ahead.
So that's why I've been thinking about ivermectin, because ivermectin has very good. Well, one of the theories in chronic fatigue is a viral, right? Be an underlying viral process.
Right. We just don't know what it is, right? Yeah.
And so ivermectin actually has really good brain penetration. So that's where the thought is it may actually resolve that some of these people may have a post-viral encephalitis type of a picture.
Okay.
Which
The
is one of
last
the
thing I want to
interesting
touch
thoughts.
on.
Sorry.
Yeah, it's okay. The last thing I want to touch on, it could be another whole podcast in itself, which maybe we will do. I want your MBA hat. I want to see if you could put your MBA hat on. What do you see as the future for affordable healthcare and access? I mean, it's a mess. I mean, we not only do
Oh
we
my God.
I know
You're acting like Middle East peace.
I know, I
Although that's
know.
happening this year.
But you always have such good answers. I thought maybe you've been thinking about this because I think about
Oh
it,
my
and obviously with
God.
COVID, it's like when I tell patients, I feel so bad for them. I mean, you and I both don't really deal with a lot of the insurances because it's such a scam these days. They don't pay for half of the kind of things that we do in our practice, and I feel bad that the patients have to lay out money. And also everybody, a lot in this gig economy, people either don't have insurance or they have
Yeah.
high deductibles. I have a high deductible. I have a 6,000 in and out of network. I pay everywhere I go.
Yeah.
It's
Well,
what
also
is the
COVID
answer?
has really
Yeah, and
COVID has
COVID's
really
yeah.
exposed this healthcare inequality,
That's
right?
what I
The
meant. That's why I
care
brought it
very
up. Yeah.
I think the way medicine is practice has to change. And so what's interesting about that is that we have to really look at more in rewarding people for taking ownership of their health
Mm-hmm.
instead of punishing them for bad health.
Right.
And I think we've really taken the approach, I call it a paternal maternal approach towards you're sick, you're bad, you did this, you're overweight, you're bad.
Right.
But
Right.
really, why not think the other way around and say, hey, let's give you incentives to do better health for yourself. And I think that's going to change the model where if people don't get as sick, the cost of healthcare does go down dramatically.
Yeah.
I don't see any other way that cost would drop.
Yeah. Okay. Well,
And as a parent, right? Negative reinforcement doesn't work, right?
I'm trying every which way as a parent. You know very well. Well, I hope my listeners feel the way I do today. Dr. Keith Berkowitz delivered just like E.F. Hutton. When Dr. Berkowitz talks, I listen. I hope everybody who listens to this enjoys the time we spent here and got a lot out of it. Again, thank you, Dr. Berkowitz.
Thank you.
I'm sure we'll be talking in the future. Take care.